Hello everyone. We are student of Ashok Mani Institute of Pharmaceutical Sciences and Research Savi. Adverse drug reaction under the subject pharmacy practice. Presented by Suhani Godse, Rachna Patil, Sanika Gaikwad. Guided by Mr. A.N. Dhage. The content of this presentation is: first, introduction of ADR. Second, reason for predisposing factor of ADR. Third, reducing or preventing ADR. 4. Classification of ADR. Fifth, difference between type 1 and type 2 ADR. Sixth, methods of detecting and monitoring ADR. 7. Management of adverse drug reaction. Due to a number of reasons, drug may produce unwanted reaction in patients. These effects occur at the normal accepted dose and not at the excessive dose. Hence, there is a requirement of a careful monitoring of the patients who are under long time therapy. Some drug adverse drug reaction are documented and hence known to the treating physician. Nevertheless, they are also counted as ADR. Some other reaction which occurs due to accidentally overdose, prescribing or dispensing error or intentional overdose are not included in adverse drug reaction. Thus, adverse drug reaction can be defined as the reaction that is harmful, unintended and occurs at dosage normally used in human for prevention, diagnosis, reasons or predisposing factors for ADR. First, stopping in midway. Patients often stop taking medicines due to various reasons like cost, ignorance, non availability, etc. There is a possibility of ADR if drugs like steroids and hormones are suddenly withdrawn. Second, factors like age, idiosyncrasy, and disease condition also caused unwanted reaction in some patients. Third, viability problems. Due to the poor formulation of drugs, blood concentration are affected and hence they may reach a toxic level in some patients, subsequently leading to ADR. 4. Intake of drug should be stopped at an appropriate time. It should not be continuous undefinedly unless otherwise indicate. Failure to set therapeutic endpoint is one of the reasons for ADR to occurs. Intake of drug like digitalis, diuretics, steroids, and antibiotics should be stopped when their continuation is not necessary. Fifth, self-medication by patient and over-prescription by doctors may also produce ADR. If any mishap or disease arises under a doctor's treatment, it is known as iatrogenic or a drug-induced disease. 6. Sex. It is a journal prescription that women are more susceptible to ADR than men, thought the reason is not established yet. It is the suspected that it could be owed to hormonal, pharmacokinetic, or immunological factor. One known example to justify this argument is the adverse effect of chloramphenicol, which is more common in the female population. 7. Age. The chances of drug producing ADR on, in fact, young children as well as on elder people are more due to underdevelopment of internal organ in the former and improper functioning of them in the later. Chloramphenicol produce gray baby syndrome on the non-native, whereas nitrous and ACE inhibitors cause hypotension in geriatric cases. 8. Apart from above, drug interaction is one of the major reasons for reducing or preventing ADR. Thought adverse drug reaction cannot be eliminated They can be reduced if the drugs are made with caution and by following certain safety except as listed below. First, patient medication history should be taken into consideration before prescribing drugs. Second, drugs should be administered only when required. If the indication is lacking, avoid using those drugs. Third, drugs should be prescribed in the minimum possible quantity. Polypharmacy of multiple drug regimens should be avoided. 4. Children and old people are susceptible to ADR, hence, they should be monitored during therapy. Fifth, continuous review of the drug requirement should be undertaken. Based on that, the dose should be reduced or altogether stopped at an appropriate time. Classification of ADR. Adverse drug reactions are classified into two different types. First, predictable and dose dependent. Second, unpredictable and independent of dose. Type 1, predictable and dose dependent. This type of ADR are most common owing to the pharmacological activities of drug, and based on that it can be further classified into three categories. First, excess pharmacological effect or toxic effect. B. Secondary pharmacological effect or side effect. And C. Return effect on stopping the drugs. Type 2. Unpredictable and independent of dose. This type of ADR is not every common. It is only occurs in some patients due to air peculiarity. 11 has nothing to do with drugs pharmacological action at the same tune. It is far more dangerous and requires intermediate stopping of the drug concern. This type can be further classified into three categories: idiosyncrasy, allergy including anaphylaxis, and genetic related. Type 1, predictable and dose dependent. A. Excess pharmacological effect or toxic effect. This may occur due to excess activity of a drug caused by long time use of drug overdose. The term drug overdose is relative. Drugs are usually given in a range of doses. Sometimes the upper range of the permitted dose is prescribed to the patient, which may result in a toxic effect in some patients. Other times, in case of kidney failure, liver disease, and anemia, some drugs cause excessive pharmacological effects even in normal doses. Gentamicin in the case of kidney failure and paracetamol in liver disease are some of the example for cases like this. Toxic effect of almost all the drugs are documented for ready reference and monitoring. Some are given below. First, heparin induced bleeding. Second, streptomycin causes deafness. Third, Emetins causes myocardial damage. 4. Coma by barbiturates. 5th. Digoxin caused atrioventricular block, and corticosteroid and anti-inflammatory drugs suppress the response to injury and infections. B. Secondary pharmacological effect or side effects. Drugs may have more functionalities even thought they are prescribed for their primary activity only. Their secondary effects are nullified by either prescribing corrective drugs or formulation techniques. However, some drug side effect cannot be corrected using an external agent. For example, steroid weaken the defense mechanism of the patient. Hence, latent disease like tuberculosis get activated. Sedation by antihistamines is another common example of secondary pharmacological side effects. C. Rebound effect. Adverse effects are not only observed for the drugs which cause dependence but also for the drug when they are stopped suddenly, usually the disease for which they were used. Relapse, for instance, if an anti-epileptic drug is stopped suddenly, seizures may increase in those patients. Similarly, if the beta blockers are stopped. Angina pectoris worsen and hypertension result if collodine, a hypotensive agent, is discontinued. Another example is the stopping of addiction forming CNS depressant, which result in tachycardia, confusion, delirium, agitation, and convulsion. These are terms are rebound response, open discontinuation of therapy. These drugs should be stopped gradually and not abrupted. Furthermore, they should be replaced with appropriate alternative drugs to prevent ADR. Type 2, unpredictable and independent of dose. Idiosyncrasy. It is the defined as a reaction due to certain unaccepted effects of drug because of the peculiarities of an individual. It is an unusual individual response to certain drugs by the patients. The response in is unaccepted, unpredictable, and dose not dependent on the dose. For example, cinchona alkaloid can quinine and quinidine produce cramps, diarrhea, and vascular collapse in some patients. Barbiturates instead of inducing depression leads to excitement and mental confusion in some individuals. B. Allergy. This is also called drug hypertensive. It is important to note that not all patients experience allergic reaction to the drug. Only a small percentage of the population goes through the reaction, contrary to popular belief. There is no sudden development. It requires prior sensitization of at least 7 to 10 days to produce the effect after first exposure. Also, the drugs could become tolerable at a later stage, and those who tolerate it earlier may develop allergic reaction over time. Different types of allergic reaction are produced in different individual for the some drugs, and sometimes a completely different drug may produce the same type of reaction. As already pointed out, they are unpredictable and food related to dose, because sometime in increase in dose cannot produce the some reaction in other individuals. On the other hand, anaphylaxis is in an allergic reaction that is severe and sudden, which may lead to loss of consciousness or even death. Photosensitivity is another type of allergic reaction exhibited by some individuals. Some genetics genotype of a particular individual can cause variation in the effects of drugs. Hence, there are possibilities of ADR sometimes to produce the same effect. An increase of 500% in dose may be required for some individuals depending on their genetics. It is because their rate of metabolism differs, and we know that the rate of metabolism depends on microsomal enzymes, which in turn is controlled by genes. The sites of action and its sensitivity to drugs also play an important role in the drug's effect, which differs due to genotypes. Difference between type 1 and type 2 ADR. Serial number. Parameter type 1 ADR and type 2 ADR. First, dependent on dose. Dose dependent, dose independent. Second, predictability, predictable, unpredictable. Third, occurrence common, rare. Four, mortality low, high. Fifth, pharmacological basis related to pharmacological properties of drug, not related to pharmacological properties of drug. 6. Management. Dose can be adjusted drug must be stopped immediately. Methods of detecting and monitoring ADR. As it is the difficult to differentiate between the disease manifestation and the adverse drug reaction. The following methods are developed to identify ADR. First, case control study. Second, cohort study. Third, spontaneous case report and vital statistic and record linkage studies. First, case control study. In this study, the group of people with the disease cases and the group of people without the disease control are compared. Here, the disease selected should be induced by the drug. Additionally, patient medication histories are collected and compared. If the drug has indeed caused the disease, it is used among the cases should be far more than the controls. This type of study can be conducted quickly and effectively, and that too at a responsible cost. However, it requires more scientific knowledge to conduct correctly and to interpret the data obtained after the study. For example, in a study of the relationship between lungs cancer and cigarette smoking, was found that the chances of the disease occurring in smoker are 10 to 11 times are more than non-smoker, as the connection between the two dependent on the amount of smoking and the scope of other factors is almost negligible. It is safe to conclude that the result of the study is justified. Second, cohort study. Cohort is a group of people with appropriately the same age put under similar conditions receiving the same drug in the study. The drug under observation is given to the group and watch for varying periods to find out the ADR. This can be for a short period, say the treatment period plus a month. The study is carried out in various places of the country, and up to 2000 to 3000 patients are selected for the process. Usually, the toxic effect due to excessive pharmacological effect are detected by this method. Moreover, the delay effects of the drug can also be detected using the same method. In the long term study lasting for a few years, up to 20,000 patients may be observed, detecting adverse drug reaction. The relevant information is collected for the doctor, pharmacist, and even the patient, if possible. However, the problems with this method is drug outs due to migration and some other related factor. It is an expensive and difficult method known as post marketing surveillance. Spontaneous case report. If a prescriber suspect and any problem with the patient because of drug uses, he reports to it to medical or para or pharmaceutical journals or to the manufacturer or the drug. This is called a spontaneous case report. This method is used to alter other prescribers. Nowadays, ADR reporting agencies are available like that the one with the World Health Organization. Once a report is sent to them with relevant particulars, they investigate and report it to all the medical practitioners through journals, news settlers, and association, etc. 4. Vital statistic and record linkage study. All the health care institution, hospital and clinics and local bodies are required to maintain morbidity and mortality data for these records. This is disease prevalence area and causes of death in a particular area can be collected and analyzed. However, this method is not often successfully because of the monsoon like long delay in the collecting data. Reliable of the data, etc. If the data is sincerely entered in records and computerization It may be useful to collect and analyze them easily in the future. Management of adverse drug reaction. Role of pharmacist. Irrespective of a careful treatment, ADR does happen owing to multiple factors that are beyond the control of the healthcare team. In those unfortunate events, the pharmacists have the following functions to manage ADR. First of all, they should review the available literature regarding the ADR of the particular drug. Any worthwhile point found should be discussed with physician. Next, the pharmacist should check the patient medication history. They should also review other factors like co-administration of other drugs, stage of the disease, etc. This should be followed by an immediate therapeutic drug monitoring if not started already. The plasma concentration of the drug in the particular patient should be analyzed and whether the reaction is dose dependent or not can be detected. Finally, depending on the seriousness of the reaction, they can advise stopping the drug. For this, they have to analyze the risk benefits ratio and the availability of subsequent drugs. If the pharmacy and therapeutic committee is available in a particular hospital, the pharmacist has the secretary of PTC should inform the committee about the ADR. PTC is discussed it and advise the treating physician what to do and how to proceed with further treatment. It monitoring the recovery of the patient for ADR and ensure proper treatment thereafter. Note that the pharmacist has to implement the decision of PTC as it is secretary. Thank you.